This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 18, Behavioral Disorders. Key concepts. Upon completion of this chapter, you will understand how abnormal behavior is culturally determined by society, that potentially harmful behavior towards self or others constitutes a behavioral emergency, that a behavioral emergency should be treated as a medical emergency until proven otherwise, how field treatment and transport includes maintaining respect, setting clear expectations, administering medications for alleviation of symptoms, and using restraints for safety. Chief concern. Highest level of mental health. Desired by most. Most are somewhat along a spectrum, high to low functioning. The ability to cope with daily stresses is what we're kind of looking at here. Key concepts. A behavioral emergency. The person exhibits aggressive behavior towards others or acts in a harmful manner to oneself, especially potentially self-destructive behaviors. Crisis intervention. Therapeutic techniques using supportive communications to provide an immediate resolution of the patient's crisis. Aggression and violence. Violent patients, we should consider the source. Patients may be afraid, frustrated, or intimidated. Aggression is a self-preservation mechanism, the inability to cope with traumatic stressors. As far as the paramedic's concerned, autonomic hyperactivity. Patient's body is under extreme stress, may manifest itself with stress-related conditions such as hypertension, acute coronary syndromes, stroke, or hypoglycemia. Neurobiology of aggression. Inhibitory and excitatory neurotransmitters bring balance to the brain. When out of balance, depression or agitation may occur. Serotonin is the chief inhibitory neurotransmitter. Low levels have been related to hyperresponsiveness and impulsivity, or make the patient impulsive. Medications may be used to balance the neurotransmitters and return the patient to normalcy. Suicide. Accumulation of behavioral emergency. Emotionally disturbed person considers or attempts suicide. Emotional behavior magnified in relation to reason. Potentially preventable, but it is unpredictable. The paramedic should consider high-risk factors. If the patient has had multiple previous attempts, the method that they've used, and the lethality of those attempts, any kind of concomitant use of depressants such as alcohol, isolation of the patient from society, elements of a suicide plan including the method, the availability of the instruments, and what stressors are present. History. Obtaining is difficult because of agitation. Some considerations: we should try to establish a rapport, speak directly to the patient, decrease environmental stimulus, reduce the number of responders in the room, move the patient to a secluded location, keep personal safety foremost in mind, the medic and the patients. Only one person should be talking at one time. Affords the patient the opportunity to focus. Record chief concerns as quoted in the patient's own words. Use open-ended questions. Allows the paramedic to listen to the answers and observe the patient's stream of thought. If possible, attempt to ascertain if the patient has a history of psychiatric disorders. Ask about medications. Be attentive to nonverbal clues, body language, agitation levels, and focus on reinforcing safety. Feelings of vulnerability increase defensiveness and agitation. Examination. Initially approaching an agitated patient, behavioral emergencies or medical emergencies first. Assess them for hypoxia, hypoglycemia, and possible head injury. All of these things can lead to confusion and delirium. Obtain a SpO2 reading and a blood glucose level. Head to shoulder examination, observe for signs of head trauma. In assessment, if we're considering medical restraint, restriction, and this would be restriction of the patient's freedom so he cannot harm himself or others, be sure that those are your clinical conditions before applying medical restraint. Violence, last remaining defense mechanism, and it's a result of fear. Indicators of violence. If they've had a history of it, a recent episode, they threaten it, excited delirium. Excited delirium is an acute change in mental status followed by agitation, hostility, and a heightened psychological state, or heightened physiological state, my apologies. Treatment. Medical restraint. It's a step-like process. Verbal persuasion should be tried first. Follow the rules of engagement for this. Consider reasonable requests. Use good therapeutic communications. And avoid counterproductive behaviors. Improper show of force. These are inappropriate counterproductive behaviors. Improper show of force. Use of confrontation. A tone that patronizes the patient. Or cornering the patient. End game for treatment. Obtain cooperation and willingness to participate. Potential for injury for both the patient and the paramedic is reduced if we do this. This is Table 814, paramedic behaviors prior to physical restraint. Clear the room in the immediate vicinity. Maintain low lights if possible. Keep the pathway to the door clear. Have a cover medic in the doorway. Never let the patient get between the paramedic and the doorway. Have help standing outside the door. Maintain a reasonable distance from the patient, out of arm's reach. Maintain an open posture. Belading the patient signals violence. Never sit or kneel. Always stay on the balls of your feet. Physical restraint. Obtained by any physical means necessary or the use of a mechanical device. Paramedics perform restraint upon physician's orders. Mental health laws state the restrictive devices that may be used for physical restraints, and the decision to elevate from a medical restraint to the use of physical restraint must be considered carefully. The patient has the right to liberty, and the use of restraint carries with it a higher risk for injury for both the patient and the medic. Procedure for physical restraint, and this is skill 18.1, physical restraint of a patient. We'll look over that. Give them enough room. Don't make be sure that you're talking to them so that you can see as their agitation level is changing. Be sure you have enough help. Whenever you decide to restrain, try to put the patient in a position to where you have multiple people to help with this. That way you're not having someone have to really escalate the force. You're kind of all holding them. It's a little bit better. The more people you have, the better it is. Whenever you restrain them, put one arm above, as is shown here. One arm above, and then one arm tied at the side. Anything that you tie down, you're going to have to assess frequently. If they're spitting, mask is appropriate. On evaluation, when restraints are used, it's imperative to regularly check and document distal circulation, motor, and neurological function. If failure to observe leads to long-term impairment, negligent claim might result to the paramedic. Management of emotionally disturbed individuals. The psychopharmacology management of emotionally disturbed persons, specifically used to control acute aggressive behavior, prevent suffering or inflicting further harm, and make the patient more cooperative. This includes antipsychotic butyrophenones like Halidol and Anapsin, and sedatives like benzodiazepines like Valium and Ativan. In some instances, a combination of antipsychotics such as haloperidol and a sedative such as diazepam are used. Allows for a lower dose of medication on both sides. Clinical effects of the haloperidol Akathisia, medication-induced movement disorder characterized by motor restlessness. An acute dystonic reaction characterized by involuntary spasmodic contractions of the face, neck, trunk, and extremities. Oculogyric crisis. Patient's eyeballs appear to have involuntary rotational movements or nystagmus. Clenched teeth, protruding tongue, facial grimacing. Extrapyramidal symptoms. Rare, life-threatening, but can be frightening for both the patient and paramedic alike. And akathisia is one of those things that we'll see in this. Acute dystonic reactions are both signs of extrapyramidal syndrome. We can treat this with the administration of a benzotropine like cogentin or intramuscular or intravenous version of diphenhydramine or Benadryl. And that would be the antidote for the reaction. Disposition. Upon hospital arrival and after a full report is given at bedside, the paramedic should make one more assessment of the restraints. Next, complete documentation, the circumstances that got you there, and the care provided. In conclusion, appropriate handling of the emotionally disturbed patient can result in an intervention that may save the patient's life by bringing them to appropriate psychiatric treatment. The paramedic, as the first healthcare provider, to contact the patient may make a difference, identifying patients who need further psychiatric evaluation and linking them with the appropriate emergency services. References were taken from Myers, Professional Paramedic, Volume 2, Medical Emergencies, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandcc.edu or 405-219-7613. Thank you.